Good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled Cardiac Safety in Oncology Drug Development, the Role of ECG and Cardiac Imaging Endpoints from a Cardio-Oncology Perspective. My name is Ryan Muse, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speakers. Now, the webinar is designed to be interactive, and webinars work best when you're involved, so please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel on the right-hand side of your screen. If you require any assistance, you can please contact me at any time by sending a message using this chat panel. At this time, know that all participants are in listen-only mode, and please note that this event will be recorded and made available for streaming on xtalks.com. At this point, I'd like to thank BioClinica, who developed the content for this presentation. BioClinica is a global life science provider that utilizes science and technology to reduce risk of clinical trials, helping companies to develop new life-improving therapies more efficiently and safely. The company's offerings include medical imaging and cardiac safety services, clinical adjudication, randomization and trial supply management and optimization, electronic and e-source data capture, site and patient payments and budget forecasting, pharmacovigilance, and trial management. Now I'd like to introduce our speakers for today's event. Jeffrey Heilbronn completed a Master of Science in Health Promotion and Disease Management. Throughout his career, Heilbronn has maintained his focus on the science, technology, trial design, and regulatory considerations surrounding cardiac safety within pharmaceutical development, with a special interest in hemodynamics. Heilbronn has supported publications in cardiac safety considerations in oncology drug development and the regulatory considerations for off-target blood pressure response in compound development. Dr. Soignier joined BioClinica as Director, Medical Oncology in April 2020. Prior to his position at BioClinica, he was the co-founder and general partner of Arcus Ventures, an oncology-focused fund investing in companies developing cancer therapeutics and diagnostics. Dr. Soignier received his BS from the University of New Orleans and his MD AOA honors from Louisiana State University School of Medicine. His internship and residency were completed in medicine at Vanderbilt University Medical Center, and he then completed his fellowship training in medical oncology, hematology at Memorial Sloan Kettering Cancer Center. Dr. Srichai is an associate professor of medicine and radiology at Georgetown University School of Medicine. She is Vice Chief of Cardiology, Director of Non-Invasive Cardiac Imaging, and Director of MedStar Women's Heart Health Program. She has over 25 years of experience in CMR and has worked professionally within radiology and cardiology. She received her MD from the Johns Hopkins University School of Medicine and MS in Comparative Effectiveness Research at NYU. She completed internal medicine residency at Columbia University Medical Center in New York and cardiology fellowship at Cleveland Clinic. And so now, without further ado, I would like to hand the mic over to our first speaker, Jeff Heilbronn. You may begin when ready.
Thanks, Ryan, and thanks to the attendees for joining the webinar today. I wanted to provide a quick overview of the concept behind the webinar and the flow of presentations. We wanted to provide a continuum look at the cardio-oncology considerations, and we're going to start from the overall oncology drug development process. Then we're going to move into the specifics related to the cardiovascular imaging endpoints and cardiac safety QT endpoints in oncology drug development. So with that, I'm going to hand things over to Stephen so that he can begin his presentation. Thank you.
Thanks, Ryan and Jeff, for the intro, and I'm happy to be here to participate in this webinar. What I'm going to do in the next 15 minutes, it's a very limited time and quite a bit of information, but I want to give you a brief overview on safety considerations in clinical drug development, but also the impact it has in clinical practice and in clinical decision-making. So where are we in oncology? Based on the American Cancer Society, it's expected that we have about 15 million cancer survivors living in the US today, with that number increasing to about 19 million by 2024. And as you can see here, most adults as well as children diagnosed with cancer today are likely to be alive in 5 years. And maybe not a surprise to the participants in this webinar, but heart disease is the second most common cause of death among cancer survivors. And we know that cancer treatments, both chemotherapy and radiation therapy, can lead to both short-term and long-term cardiovascular complications. Just to review, in terms of clinical trials, or rather what we refer to as the pre-approval clinical trials, realize that there are safety limitations of information that we get from these studies. And it's just by the nature of the studies, because in the study population, those patients are in a trial look completely different or have a significant different sort of phenotype of what will happen once the drug gets into the market and used clinically among multiple practices. The other difference is that in clinical studies, often comorbidities are limited because you don't want to confound any sort of potential safety signal coming from the development of the drug. The duration of study is also significant. In clinical trials, patients are only exposed to the drugs from weeks to months, where once the medication is out into clinical practice, we start getting a much thorough review of potential adverse effects because the drugs are generally given for months and maybe up to years in multiple cycles. Just high-level review, sort of phase 1 studies, there are generally a small number of patients that are entered on these trials. They can go as high as up to 100 patients, and that's when we do combination monotherapy combination trials. The objective of these studies is really to establish the maximum tolerated dose, which is usually defined or limited based on cytotoxicities, adverse events for the more conventional cytotoxic agents. And we establish biologic effective dose using more PK/PD pharmacodynamic assessment targets, looking specifically in targeted therapies. Now, the safety challenges in phase 1 studies is that by far the majority of these people that are going to be entered in the trial have advanced stage diseases and they've had multiple prior treatments. Often they are present with residual toxicities from the prior therapies, and because of the age of most of these patients, they have comorbid conditions and they're on multiple medications. And this is important, particularly as we look about the potential risk for drug-drug interaction with the investigational agent. Phase 2 studies, these are a bit larger than our phase 1s. The objective of these studies are specifically to mitigate the specific adverse effects that may be seen with the new investigational agent, optimize the dose schedule to achieve the highest potential benefit risk profile going to phase 3. So in phase 2, it's very often these are very selected patient populations, as I give an example here in platinum-resistant ovarian cancer, and they have specific exclusions, again, to mitigate the potential confounding effects of getting an early safety signal from the investigational agent itself. Phase 3 studies are much larger, and these are based on guidance from the FDA about what needs to be achieved for the drug to be considered for FDA approval. In that approval review process, they will review all the integrated summaries of efficacy as well as safety, and this is where we get our initial black box warnings once a drug gets into the market. But I want to point out that often in these earlier studies, there is limited drug-drug type interaction, drug information, and as well as the dose adjustment based on organ function. As a result of the more collaborative effort of the FDA, we're seeing that drugs are getting to market on a much faster basis. And as a result, the FDA is starting to put more weight on requiring additional phase 4, what we call post-approval surveillances and pharmacovigilance type studies. And this is with the intent to capture some of the unpredicted serious side effects that we don't see in the early clinical development phase, other low frequency reactions, the impact of the drug in high risk groups, which is more likely who's going to be getting this drug anyway in clinical practice, maybe long-term or chronic type effects, and additional drug-food interactions. Just to kind of give you an overview of the armamentarium in oncology, sort of the era of cytotoxic agents were first developed, came about in the 1940s with the identification of nitrogen mustard and folic acid antagonist. Since then, they have really, cytotoxic agents have become the staple of cancer therapeutics and still today in most cancers. The mechanism of action of these agents were very plain. They targeted rapidly dividing cells, that included both normal and cancerous cells. So not surprisingly, often the dose-limiting toxicity or maximum tolerated dose often was related to bone marrow suppression, which resulted in neutropenia and had significant morbidities, mortalities, and anemias. But they certainly had other organ toxicities, and it was very specific to some of the various cytotoxic agents. What I really want to bring your attention to is the last, and that's the acute and chronic cardiac toxicities, particularly that's been identified with the class of drugs, cytotoxic drugs called anthracyclines. By far, anthracyclines are the backbone of treatment of many hematologic and solid tumors. But one of the disadvantages that it has been established that it has a risk for cardiovascular dysfunction, particularly related to the cumulative dose. And this is referred to as type 1 cardiotoxicity because this is irreversible. I'm going to talk about this more in another slide or two. Immunotherapies kind of entered the market in the late 1980s with interferons and interleukins. They had limited use because of the side effects, mainly almost like a cytokine type release syndrome, causing vascular leak, hypotension, and cardiac arrhythmias. Monoclonal antibodies entered into the oncology in the late 1990s with the introduction of rituximab, trastuzumab, and this is really the beginning of the revolution of what we're seeing with immunotherapy now getting integrated in oncology. In addition to monoclonal antibodies, there are now subsequently bispecific antibody drug conjugates. The concept there was that you use an antibody as a smart missile to deliver a payload of cytotoxic agent to the cancer cells. More recently, you've heard about CAR T therapies in the last 5 years. This is a very sophisticated and complicated treatment where it involves that the patient's T cells are removed from their body using viral vectors. They manipulate the T cells to particularly become sensitive to the cancer cells, expand these cells and infuse them back into the patients. And all these immune therapies have, again, very specific toxicities that require not only short-term monitoring, but long-term, and also include cardiotoxicity. Probably the biggest impact from immune therapy in oncology today has been the introduction of checkpoint inhibitors. The first of these agents, called ipilimumab, was introduced in 2011. Now, the checkpoint inhibitors are monoclonal antibodies that target the host immune negative regulation receptors. So, for example, in this cartoon on the right, you see the PD-L1 receptor on the, say, this would be cancer cells, and the PD-1 on the T cells. When the antibodies are placed in and it blocks the engagement of the T cell with the ligand on the cancer cells, it essentially unleashes the immune system to destroy the cancer cell. Well, unfortunately, we also see that it can affect other healthy cells as well. Very interesting is when the first checkpoint inhibitor was approved, it was speculated that maybe 1 to 2% of the patients would be eligible for a checkpoint inhibitor in 2011. By 2018, this number had been increased to 44% of cancer patients likely to be eligible for a checkpoint inhibitor. And now in 2000, it's north of 50%. Currently, there are 7 approved checkpoint inhibitors with several more currently in development and soon to enter the market. This class of compounds have very specific immune-related side effects. It can affect any part of the body, endocrine system, and by far it affects mostly the colon and the lung, causing colitis, pneumonitis that has the biggest contribution to morbidity and likely the more reason why a patient would stop a checkpoint inhibitor. Myocarditis has been reported in less than 1% of the patients, but the significance of this is that it has associated with a very high mortality rate of about 50%. Johns Hopkins reported their experience of side effects with checkpoint inhibitors a couple of years ago. And what was interesting, what they noted is that 71% of the patients that got a checkpoint inhibitor were likely to exhibit any of these side effects within the first 3 months, which was a little surprising is that in following these patients, after stopping the checkpoint inhibitor, almost half the patients were still having symptoms as a result 6 months later. Now, what's the significance of that? Well, from a clinical and investigational perspective, it's the considerations that these residual toxicities can certainly impact the potential treatments that this patient would subsequently get. Target therapies were introduced again in the beginning of the early 2000s. These are more designer type drugs to block specific molecules driving growth, proliferation, and survival in cancer cells. This is just a list of various pathways and some of the drugs and disease that they treat. What I want to emphasize is that the introduction of target therapies has certainly have improved the benefit-risk ratio. But the optics of this need to be clear. This is more like shooting a fish in a barrel, because if you know you have a known specific mutation, a cancer that has a drug that alters it, you are going to get a much higher response rate. But that's not taken away from the denominator in considering the adverse effects. As a result, many of these target therapies also are given for require chronic dosing. As a result, there's a potential for more longer-term side effects that are not going to be seen in the initial clinical studies. And it also increases the potential for drug-drug interactions with other medications that the patient may be on, and particularly investigational therapies. I want to use this case study to kind of show you what safety does and considerations of treatment options for patients. This is a 50-year-old that was diagnosed with stage 2 invasive breast cancer, who underwent a mastectomy and was referred to oncology for adjuvant chemotherapy. And the adjuvant chemotherapy, because we know that stage 2 breast cancer have a pretty high risk of recurrent disease. Significant past medical history of this patient includes her being diagnosed with Hodgkin's lymphoma at the age of 17, treated with a combination therapy called ABVD that entailed adriamycin, and she was then consolidated with mediastinal radiation. You also can see that she had coronary artery disease, hypertension, gastric reflux disease, and hypothyroidism. And all those comorbidities she has are probably all in part related to her prior chemotherapy. The list of medications are really important when we think about treatment, because these medications, the way that they metabolized, the adverse effects they had could impact any investigational or standard therapy that we give. In the medical workup of this patient, her tumor expressed estrogen and progesterone receptors, which it has positive prognostic implications, but her tumor also expressed HER2 positivity, which has negative prognostic implications. Her labs are normal, as was her EKG, and her echo showed she had an ejection fraction of 60%. So standard treatment options for this patient to be considered, as you see listed here, there's the first one as an adriamycin-based regimen, and then two others that have non-anthracycline-based regimens, but they all include trastuzumab, then which would be followed by endocrine therapy because of the ER/PR positivity of her tumor. Potential clinical trial that she could participate in or be considered for would be any of those chemotherapies, but with the addition of pertuzumab, which is an antibody like trastuzumab, targeting the HER2 of the cancer cells, and that with the expectation that it could improve overall response and decrease risk of recurrence. However, the important understanding, discussion, and goals of treatment needs to be had with the patient, and it's getting to the point of talking about disease-free survival versus overall survival with or without disease. And in this particular case, it's really going to be about cardiac safety, particularly considering anthracyclines. We know that anthracyclines have been proved in multiple studies that an anthracycline-based chemotherapy regimen for adjuvant breast cancer versus non-anthracycline, that the anthracycline regimen has an improvement of greater than 10% in disease-free and overall survival compared to a non-anthracycline-based regimen. We also have to take into consideration that the incidence of heart failure, potential heart failure, with an anthracycline regimen combined with trastuzumab is about 2%. Without an anthracycline, it's less than 0.5% and closer to the control. The thing is about anthracyclines, as I mentioned earlier, they induce type 1 cardiotoxicity, which is irreversible. Dr. Van Hoff had reported in the late 1980s, early 1990s, that the cardiotoxicity from anthracyclines is related more to the cumulative dose of the drug that they have. So in this circumstance, and for this particular patient, With her Hodgkin's lymphoma treatment, she received a total dose of 285 milligrams of adriamycin, also doxorubicin, known as doxorubicin. If she were to get the anthracycline-based regimen in this adjuvant breast cancer treatment, it would require that she get an additional 360 milligrams, bringing her cumulative dose about 650 milligrams. And if you look here, that would mean she'd have about a 25% chance of cardiotoxicity. And it's illustrated here about the same range on this lower chart. Now, the problem for this patient is that her tumor also expresses HER2 receptor, and so requires the drug trastuzumab. Trastuzumab in itself causes type 2 cardiotoxicity, which fortunately is reversible. And the reason why the drug causes toxicity is what we call on-target but off-tumor effect. That is, the trastuzumab will bind to the HER2 receptors on the cancer cells, but it also binds to the expression of HER2 on the cardiomyocytes, and therefore inducing toxicities. If you look at this chart here to the right, you can see that the risk of cardiotoxicity when you combine trastuzumab and doxorubicin occurs at a much lower load of cumulative dose. So considering this woman would, if she were to get this adriamycin-based regimen, her risk of cardiotoxicity is way too high, and it's formidable for her regimen. An important point I wanted to also say about monitoring earlier safety signals. In the earlier development of trastuzumab, it was noted that in the phase 3 studies that 25% of patients developed symptomatic cardiac dysfunction and heart failure. In subsequent adjuvant studies, when they required routine imaging using echo at baseline every 3 months, the symptomatic heart failure was reduced to less than 3%. And this has become really the standard use in the standard guidelines now with the use of these drugs. Here's just a list of drugs I'm going to quickly go through that are associated with heart failure and left ventricular dysfunction. And here's some prevention strategies and treatment interventions, but you realize it's almost all class of drugs. Agents associated with myocardial infarction and ischemia. Some of these in some studies, particularly if the patient had cardiovascular or coronary artery disease, the potential incident rate could be quite high. This is just a list of drugs that are associated with atrial fibrillation, bradycardia, and hypertension. I really want to note this because we're talking about hypertension that can be very severe and require significant management and close monitoring when they're on either any of these agents in the market or any of these agents similar to this in investigation, being investigated. QT prolongation and the cardiac arrhythmia torsade de pointe is certainly a concern with a lot of chemotherapeutics. This QT prolongation is one of the most frequently encountered electrical disorders of the myocardium. The causes are multifactorial, including congenital, acquired conditions as listed here, but mostly medications. And this just is a rhythm strip showing the QRS, which is indicative of the electrical activity of the heart when it contracts and relaxes. This particular QRS shows that there's QT prolongation, and this is where you get the risk of going into this arrhythmia called torsades de pointe. And when you see this on an EKG strip, this is pretty much telling you that the patient has no cardiac function, low cardiac output, and they require immediate intervention to prevent death. Here's a list of the spectrum of molecular target agents with QT effects. I want to also specifically point out the tyrosine kinase inhibitors, as there are over 45 of these on the market. In addition to QT prolongation, they're associated with systemic pulmonary hypertension and left ventricular dysfunction. Some of the strategies we're doing to improve the benefit-risk index of cancer therapeutics, we're starting to see trials where we do risk and responsive adaptive approaches, where we're using other tools in our toolbox to help make assessments about which patient would benefit with more chemotherapy or less. So for example, in Hodgkin's lymphoma, they get the standard ABV therapy. They get 2 cycles. We use PET scans to look at the metabolic activity. If it's resolved, we would either continue that therapy or de-escalate. If it remains positive, we would escalate the intensity of therapy. The benefit of that would be that we're certainly going to get a high response rate and potential cure rate, but it's going to come at the cost of more toxicity. We're using polymerase chain reaction to assess minimal residual disease in leukemia patients to determine who would benefit or may not benefit from a bone marrow transplant. Gene expression profile in breast cancer patients, early stage to see who would benefit from adjuvant chemotherapy and to avoid adjuvant chemotherapy in those patients who would not need it. From a safety perspective, using other markers, we're using genetic polymorphism markers and what we call SNPs, or single nucleotide polymorphisms, identification to say which patients may be at greater risk from toxicities from drugs like anthracyclines. If they're there, then earlier interventions are done and our alternative drug considerations are given. But most importantly, on a continuum, what we're finding is that the use of biomarkers early on and during the earlier phase development, as well as EKG monitoring and imaging, particularly for cardiac toxicity, which we're going to hear our next speaker talk about, really has the greatest impacts. Management in oncology has now become more of a multidisciplinary approach. We now have a specialty of cardiology oncology that have really developed the protocols where we use anthracyclines and Herceptins that oncologists use and follow to mitigate and reduce risk of toxicities. And breast cancer, despite the increased diagnosis, we see that there is a trend in the decreased death rate. And that's because of these safety interventions and the way that we're starting to use these additional new targeted therapies and safety monitoring. And as a result, we're seeing an improvement in the 5-year relative survival rate. And this is really across all tumors, not just breast cancer. So where are we in oncology? I think we've made significant advances in cancer therapeutics and outcome, which is evident by the disease-free survival and overall survival trends. And we think about oncology and cancer patients differently from the concept of cure to chronic management. With some of the newer therapies, because of the chronic use of them and their long-term response, this does require careful monitoring and management to mitigate the associated morbidity and mortality. Certainly, cardiovascular safety has become a major public health challenge, and it's obvious that it's recognized as we're seeing increase in public information, the beginnings of cardio-oncology journals, specific cardio-oncology clinics, and subspecialty training in this area. Because of the way healthcare practice is going, where we need the additions of physicians, nurses, pharmacists, nurse practitioners, physician assistants involved in help monitor and prevent and be engaged in the monitoring and prevention strategies, we have to really make sure that we're filling in this knowledge gap. There's certainly going to be an ongoing need for monitoring and establishing practice guidelines to assess for cardiovascular safety throughout not only the drug development stage, but also post-approval. So I'd say, where are we? I'd say we certainly have made advantage. We have made a lot of progress, but we certainly have a ways to go, particularly with the newer therapies that are coming on. So at this time, I'd like to pass the discussions over to Dr. Srishai. Thank you.
Hi, thank you, Stephen. And thank you, Ryan and Jeff, for allowing me to be a part of this program today. I hope everybody can see my screen. I'm going to be speaking today about cardiac imaging and cardio-oncology, kind of give you a little bit of where we stand clinically and at the crossroads with drug development. So the world of cardio-oncology really represents the intersection between cancer and cardiovascular disease. Cancers can arise from the cardiac tissues, but more commonly, the cardiovascular disease we see with oncology was related to the treatments that patients are receiving. And as we heard from our first speaker, cancer therapy really affects nearly every aspect of the cardiovascular system, from the arteries to the valves, to the myocardium, to the pericardium, to the conduction system itself. As was mentioned, anthracyclines probably represent the most common chemotherapeutic agent that's been associated with cardiotoxicity. So we can see here it's related in a dose-dependent manner with development of congestive heart failure, which can occur early on in the cycle. But radiation therapy is associated with a lot of cardiotoxicity as well, although the toxicity isn't usually seen until later after treatment has been given. So patients may present later in life, often after their oncologic treatment has completed. And so where does cardiac imaging serve in our cancer population? It's helpful for giving us a baseline cardiovascular risk of our patients who may be undergoing or starting treatment. Allows for timely diagnosis of early cardiac dysfunction in patients who are undergoing treatment. Picking out patients who could benefit from cardioprotective treatments while they're undergoing their oncology treatments. And then finally, for identifying patients who may benefit or require long-term cardiovascular follow-up. There are several tools that we use to look for cardiotoxicity, and I'm going to focus on the imaging-based ones, starting with echocardiography. And so really, 2D echocardiography is the cornerstone of cardiac imaging for a variety of cardiovascular disease, and left ventricular function, which is commonly used to identify cardiotoxicity, is most commonly performed with echocardiography in the clinical setting. Oftentimes, the reader will look at the image quality, the images obtained, and get a visual estimation of the cardiac function. There are quantitative evaluations that are available as well and are commonly used, particularly in our cardio-oncology population. But often, because it's of the 2D nature of image acquisition, require geometric assumptions to get to a quantitative analysis of ventricular volumes and ejection fraction. "3D echo allows for full volumetric acquisition of the heart, and so now we have we are not limited to geometric assumptions or limited planes in order to calculate quantitative aspects of ventricular volume and ejection fraction. And now there are several in our current era, several post-processing tools that allow us to quantitate using these volumetric data sets in a smooth and easy format. The clinical guidelines currently recommend 3D imaging if possible in labs with experience, but also 2D imaging using the modified Simpson's biplane method for quantification of LV function. With 2D imaging, though, as I mentioned, there can be multiple limitations, particularly the geometric assumptions that have to be made in order to get to a quantitative number. Also, if a patient has inaccurate or suboptimal image quality or a lot of wall motion abnormalities, using these geometric assumptions may lead to inaccuracies in the actual quantitative numbers that are obtained. 3D images allow, since we now have the full left ventricle available for analysis as a single volumetric data set, we no longer have to use these geometric assumptions in order to do our quantification. And 3D imaging is shown to be more strongly correlated with cardiac MRI for ventricular function and ejection fraction, whereas cardiac MRI is considered the gold standard for these parameters. However, with 3D images, the incidence of suboptimal image quality is increased compared to with 2D images. And particularly with our oncology patients and thinking about the breast cancer patients, the treatment themselves that patients undergo for their breast cancer often will lead to worsening image quality, particularly with 3D imaging compared to 2D imaging. Another parameter that has been used and becoming more frequently seen in the clinical literature is that of myocardial strain, which is looking at local shortening, thickening, or lengthening of the myocardium. So you can see in the image here, the muscle fibers are arranged around the heart in a longitudinal as well as radial or circumferential format. And by assessing the change in these lengths, this gives us another parameter of regional function. Speckle tracking echo is the most common technique used now for calculating myocardial strain. It allows for calculation in all three dimensions shown up top, longitudinal, radial, and circumferential, with high reproducibility. This is a 2D technique, but there are 3D speckle tracking echo that is coming online, although still in the research phase, but may overcome some of the limitations that we have with 2D imaging and allow for faster image acquisition and complete calculation of ventricular function, as well as ejection fraction and strain all in one data set. When we think of the different parameters that are ongoing now for calculating left ventricular function, a global longitudinal strain, so in the long axis direction, has emerged right now as a new marker for detecting subclinical ventricular dysfunction. So picking up that there's something going on with the myocardium before we actually see a drop in the ejection fraction. Global longitudinal strain has a stronger association with prognosis, as well as higher sensitivity and reproducibility compared to left ventricular ejection fraction. And as I mentioned, has the potential to accurately predict whether a patient is going to have a further decrease in their overall ejection fraction and therefore significant cardiotoxicity. In the clinical realm, however, we do not rely solely on global longitudinal strain to make changes into a patient's cardio-oncology regimen. However, the SEQUOIA study is currently prospectively assessing the value of initiating cardioprotective medication that's triggered by a drop in global longitudinal strain, as opposed to waiting until a patient has a drop in their ejection fraction. Moving on to nuclear cardiac imaging. So MUGA scans used to be the cornerstone of cardio-oncology and assessment of ventricular function. Currently, however, they're not recommended as a first-line imaging technique, mainly because of the radiation exposure, as well as lack of additional information that can be obtained about the cardiac structure and function. There are newer techniques that are coming on the market, including SPECT-MUGA, that can address some of these limitations with lower radiation dose. FDG PET scanning is already commonly used for oncology surveillance, and in patients who have myocarditis may be an alternative to MRI for detecting cardiotoxicity. Again, mainly because patients are already undergoing FDG PET for surveillance. In this particular example here, this was a patient who underwent treatment for lymphoma, showing the baseline imaging parameters, and then at the end of therapy, we see there's significant FDG uptake within the myocardium. And further workup, including an echo, showed that the patient had significant LV dysfunction. More commonly, it's specific tracers that can be used in specific scenarios where we see the growth in cardiac nuclear imaging. Here on the left, use of pyrophosphate imaging for identifying amyloidosis within the heart structures. And on the right, use of radiolabeled octreotide for detection of cardiac carcinoid metastases. Moving on to cardiac MR. Cardiac MR is not routinely used for surveillance, mainly because of its lack of widespread availability and its relatively higher cost compared to echocardiography. However, when it is available, it can be very useful. As I mentioned, it is considered the gold standard for quantification of ventricular volumes and ejection fraction. But in addition to evaluating cardiac function, it also allows for concomitant tissue characterization, which can be important for understanding the pathogenesis of cardiotoxicity with the different drug classes, as well as radiation exposure, and also may provide one of the earliest markers for detection of cardiotoxicity. Bright blood cine MR imaging is probably the workhorse of cardiac MR. I don't think you would see an MR scan with an MR protocol, cardiac MR protocol, without some of these images in there. This gives us good visualization of the myocardium for evaluation of function, as well as good visualization of the valves. And from these images, this is where we can do quantification for ventricular volumes, both left and right ventricular volumes, and ejection fraction. And as I mentioned, this is the gold standard for calculation of ventricular volumes and ejection fraction. But as I mentioned, it's the strength of MR is also its ability to characterize the tissues and give us more information about what could be going on at the myocardial level. Dark blood images with T1 and T2 weighted sequences allow for assessment of myocardial fat and or necrosis, as well as T2 weighted images give us information about whether there's fluid buildup or edema or inflammation, particularly in the myocardium or in the pericardium. And then more sophisticated parametric mapping sequences allow us to quantify other aspects of the tissue. T2 star mapping can be used to quantify iron within the heart as well as other structures in the body. T1 mapping can be used to detect diffuse fibrosis, both without contrast or with the contrast. And then T2 mapping can enhance the detection of edema, particularly in patients who may have myocarditis. And then finally, late gadolinium enhancement imaging. This is considered the gold standard for evaluating myocardial infarction and fibrosis, and has been shown to correlate with overall prognosis in terms of cardiovascular disease. Similar to echo, MR can provide information about myocardial strain. There are several different techniques that have been used to assess this with cardiac MR. But they're often time consuming because they require extra acquisitions. What's been used more frequently now, though, is feature tracking, this image on the right bottom, because it allows post-processing based on imaging that's already usually obtained as part of a regular cardiac MR protocol. So I've shown you a lot of different image sequences and techniques. When we build a cardiac MR protocol, we can't do everything in every patient, and so we will tailor the protocols based on what we're trying to look for. And so, as I mentioned, all of the protocols usually will include bright blood cine imaging, and then we'll add in these other sequences depending upon what the structure of interest is or what the thought of mechanism is. Cardiac CT. The growth of cardiac CT has mainly been in the coronary artery arena. Non-contrast studies can be used to detect calcium because it's exquisitely sensitive to calcium. And calcium within the coronary arteries signifies the presence of atherosclerosis. There's a wealth of data out there that, and this is 15 years of data that shows that the higher the calcium, the amount of calcium within the coronary arteries, the worse prognosis for patients. With the addition of contrast into the CT, however, now we get a lot of additional information beyond that of a calcium score. We can look at different characteristics of the plaque as well as see if there's actual obstructive disease or not, and how many vessels are involved. And all of these parameters have been shown to be important for prognosis. So in summary, the standard tools that we use for detecting cardiotoxicity, as I mentioned, echocardiography is the cornerstone, and a left ventricular ejection fraction has been the most commonly used parameter, 3D or 2D based techniques, and a drop in ejection fraction of at least 10 percentage points where it drops below the lower limit of normal, which is usually considered around 50 to 55%. That suggests cardiotoxicity. As I mentioned, global longitudinal strain is coming into the mainstream, and a change of about at least 15% can be suggestive of cardiotoxicity. MUGA scans, as I mentioned, not used as first line, but can be important as a second line imaging modality. And then cardiac MRI, typically if the other techniques are suboptimal, can be very useful for both function as well as identifying additional information with tissue characterization. What about its use in oncology trials? So as we heard, imaging biomarkers are often used as a surrogate marker to identify cardiac safety and can serve as a primary efficacy endpoint for certain oncology trials. In addition to evaluation of ventricular function, these highly sensitive imaging techniques can also give us information and identify potential pathologic changes that are ongoing prior to a patient becoming symptomatic and or prior to their left ventricle becoming dysfunctional or development of cardiomyopathy. This is important because it allows us to make decisions regarding continued drug development, understanding patients' baseline cardiovascular risk, help identify high-risk subgroups within the population under study, screen subjects for eligibility into a trial, and then to also, as with clinical evaluation, monitor patients for changes that may lead to dose adjustments or discontinuation of their oncology treatment and or addition of cardioprotective treatment. Similar to the clinical evaluation, echocardiography has been the primary imaging technique for cardiac safety assessments, mainly because of its wide availability, its lower cost compared to other techniques, limited contraindications, and the wealth of information beyond cardiac function that can be obtained with echocardiography, as well as development of new techniques, including 3D imaging, to help with some of the limitations that's experienced with 2D imaging. There are limitations, though, with echocardiography. The most commonly used parameters, including ventricular size and ejection fraction, don't measure the intrinsic myocardial function and can be influenced by other factors beyond strictly myocardial function. And therefore, the other aspect is that changes that we may see in the short term in ejection fraction or volumes may not actually accurately affect long-term effects on survival. In addition, with echocardiography, there's moderate inter-reader variability as well as suboptimal reproducibility. And some of this is compensated by the use of core labs and larger sample sizes in order to adjust for this. Finally, image acquisition quality is highly dependent on a sonographer's skill, experience, as well as the type of equipment that's being used to obtain the images. Alternative modalities that can be used for surrogate endpoints, as I mentioned, cardiac MR allows for improved accuracy and reproducibility. It's considered the gold standard for LV volumes, ejection fraction, and mass calculations, actually. And that may actually facilitate a reduction in sample size if this is the primary endpoint that's being used. But it also allows for detection of other myocardial aspects that may be important depending upon the drug undergoing study and the specific therapeutic effect that we're looking for. With nuclear cardiac imaging techniques, they can also provide additional novel insights into the pathophysiology going on with the drug and its effect on the heart. The hurdles to more widespread use with these agents, with these techniques, however, is its availability is limited to only select centers. It's relatively higher cost compared to echocardiography, longer examination times, and other potential contraindications. Oh, whoops, sorry. So in summary, echocardiography is the initial imaging modality used for assessment of cardiotoxicity in the clinical realm, and also the most commonly used technique in evaluation of cardiac safety for oncology clinical trials. Cardiac MR is typically recommended when echo is non-diagnostic or if we want to confirm that there is the presence of LV dysfunction. Nuclear and CT imaging techniques are not routinely performed due to radiation exposure, but can be useful in specific scenarios. And finally, cardiac MR nuclear techniques can be useful in clinical trials. It allows for improved diagnostic accuracy and reproducibility in cardiac function, which could facilitate a decrease in overall sample size needed with clinical trials. And in addition, more importantly, can offer additional insight into the mechanisms of cardiotoxicity and earlier identification of cardiotoxicity. Thank you. And I'm going to pass the baton on to Jeff, who I think will be our third speaker.
Yes, thanks very much. And you should be able to see my slides now. And again, thank you for the opportunity to present today. And we're going to talk right now about the ECG component in the cardiac safety considerations for oncology clinical trials. During my presentation, just a quick overview of what we'll speak about is how did we get to and where we are now with the QT cardiac safety considerations in oncology drug development. Again, always taking a look at the benefit risk assessment and the increased focus on the concentration QTC modeling and the question regarding the TQT and can it replace it? Now, I'll take a moment here to emphasize that in non-oncologic products, the concentration effect analysis can replace a TQT, but in fact, in oncology products, the concentration effect analysis is really the only option, and we'll talk about why that is. If there's one thing you should walk away from my presentation today, is that you should take a look at the ICH E14 S7B working group Q&A from this summer because it really did do a good job in outlining the expectations regarding the QT ECG cardiac safety in special considerations. I did take a focus in my presentation about some of the frequently asked questions that come up when, again, implementing ECG into an oncology clinical trial. So what we have on this slide is a very simple cartoon or description of really the overall concept of cardiac safety QT and the adaptation for it when we come into the oncology indication. So recognizing that things began in 2005 with the ICH E14, one of the things that many people may or may not be familiar with is that in 2006, CDER established the Interdisciplinary Review Team to assist sponsors in the establishment of the QT and or thorough QT clinical trial. You can connect with this IRT through your review divisions. You can't contact them directly, but you can put a request in through your review division. And then you can see as we go down the line to what I had mentioned just previously about the ICH E14 S7B Q&A. It's well understood that within the cardiac safety and the QT arena that we can't run a thorough QT in a majority of the oncologic agents because we can't work with healthy volunteers and we can't treat patients the way that we would treat healthy volunteers. And you can see when you read that ICH E14 Q&A, it really outlines a very nice approach, taking a look at an integration of the non-clinical and clinical QT risk assessments. But also what many people overlook is taking a look at the latter phase or the cardiovascular safety database, and does it in fact suggest an increased risk of adverse events. My presentation is going to focus more so on the early phase development. So there's a poll question we're going to run by real quick.
Yes, we have a poll question for audience members to interact with in real time. You can click on any of the two answers you see in front of you and then click submit. And the question is simply, have you ever interacted with the FDA QT IRT group to review the ECG QT approach for a study? Please take a moment now to answer either with a yes or a no. We greatly appreciate your participation as the answer applies to yourself and the company that you work for. We'll give you another moment to get your answer into the question, which is, again, have you ever interacted with the FDA QT IRT group to review the ECG QT approach for a study? It looks like most of you have voted, so let's go ahead and take a look at how those results have turned out. 81% coming in saying no, but 19% saying yes. So thank you very much again for your participation. I hand it back over to you again, Jeff.
Thanks, Ryan. So I have up on the screen now a slide coming from an FDA presentation. And the reason why I'm sharing this is it just shows the evolution of the concept of the concentration QTC, not specific to oncology, but so that you, as a developer, recognize that there has been a lot of background work and assessment of the value of the concentration QTC in the drug development and cardiac safety process. So now that we move into oncology itself, what are the things that we need to take into consideration? And these are some key points that are, again, from the ICH Q&A, as well as some research papers on concentration QTC model. First of all, in fact, we know that when we're looking at an oncology population that we do have patients who are going to be on multiple therapeutic agents, and it can be difficult to isolate the concentration of the other drugs versus just the therapeutic agent in development. We do know, of course, that since we're not working with healthy volunteers that would be participating in that TQT or that cardiac safety study, that we have to take that into consideration with that patient population. And in fact, they may come to a study already having cardiac safety signals. And of course, when looking at this, we know that we can't do certain activities with this because of the oncology patient population, such as a placebo arm or a positive control arm. And again, we are often limited by where we can expose the study participant to the therapeutic agent, because going upwards and beyond to a super therapeutic dose, which would be part of a thorough QT, really isn't feasible or ethical in the conduct of an oncology clinical trial. And again, as referenced before, we want to take a look at the overall cardiac safety information going from the in vivo all the way up to the clinical trial component of things, and designing your trials to be an alternative, but similar to the thorough QT based upon specific features. The slide here is really just, it's not to an oncology compound, but it's more for those that may not have the familiarity with the concentration effect. And this is just showing, if you look on the y-axis where we're seeing the change in baseline in the QTCF versus the concentration effect, you can see what's nice about this is that in this study, they were able to take the population all the way out to a relatively high concentration, although not as many sample points as where we see in the early phase. So this is the concept that the regulators would be looking at, is how close your confidence intervals are related to that exposure to the study compound and the change in the QTC from baseline. So when taking a look at this, one of the things that is important, and something that Dr. Srishai pointed out, it is also what's happening at the site level. And so when we are looking at implementing this from a protocol design, of course, we want to make sure that we're doing the triplicate ECGs in association with the PK schedule. That's a critical variable, but it is actually the acquisition of the ECG data that is as important. And so you're going to want to work closely with site staff on the key considerations of quality ECG capture and management of the patient, which would include ensuring that the patient does maintain a certain position and rested situation when it does come time for the time points for ECG capture and blood draws, and the importance, and I think it's often overlooked, of explaining to the study sites why is this important that we conduct this study and this focus on the ECG data collection. This is just a very quick snapshot of what can be seen in some of the protocols where they're outlined in the schedule of events. And what you try to do is try to correlate this. So it does say that there'll be Holter monitoring in the study on cycle 1, day 1, and cycle 1, day 15. But there's a little bit of a disconnect to the PK sampling. And so it's often suggested that whether it be in the protocol or in some sort of supplemental, that you do an outline so it's very clearly seen. There is a difference between the ECGs that you're going to capture for the PK and those that might be outlined in the schedule event for safety assessment. And in a similar fashion, this one caught my attention because they had clearly outlined a lot of PK data. And so a great opportunity to correlate that with the QT and cardiac safety information. And so the feedback going to this sponsor was, have you considered collecting additional ECGs to be able to help define if there is in fact an exposure response or an association to an increased cardiac safety signal. And again, if there is a signal, that doesn't mean the drug stops in development. What it means is that you've done the responsible, you've provided the information needed to really move forward with the drug as the potential cardiac safety risk. So as we take a look at some of the frequently asked questions that come up, I won't have time to review all of them. Glad to follow up with anyone who's interested. We often see questions coming in. Should I use a standard 12-lead ECG device or a 12-lead digital Holter? I personally think that using the digital Holter is a very efficient and effective way to collect the data and then extract the ECG time points in association with the PK. Discussions and questions have come up around, can you use the study ECG machine at the site, or do we have to use the standardized equipment? I would say that in most cases, there is a benefit to using the standardized equipment because you do want to capture that digital ECG for the analysis process. And then we'll go on to 3 and into 4 about how many pre-dose ECG time points do I need. It is important to include those pre-dose time points because, in fact, they become your baseline and they're critical. I normally would suggest capturing a minimum of 2 pre-dose baseline because, again, you're going to compare that delta to that cycle 1, say day 1 exposure, and you're going to need that baseline ECG to do that. So I do reference that there is no direction coming from the regulators as what the mandate is. It's more a statistical question. And whenever we take a look at this, when it comes to the ECG time points, always keep in sight your PK, because that PK sampling and your knowledge of the pharmacokinetics of the drug is the key. Because again, what we're going to try to show at the end of the day is that based upon increased exposure to the therapeutic agent, do we see a potential increase in the cardiac safety QT or QT risk associated with QT prolongation? So with that, I'm going to stop and hand things back over to Ryan, and thank you for your time.
Well, thank you very much, all three of our speakers, for that wonderfully insightful presentation. Before we end today, I'd like to take a moment to draw our audience's attention to the handouts module within GoToWebinar, where you'll find some documentation provided by BioClinica in relation to today's presentation. If you have any questions regarding today's presentation, you can direct them to the email addresses that are on your screen right now. I want to thank everyone for participating in today's webinar, and you'll be receiving a follow-up email from XTalks with access to the recorded archive for this event. A survey window will be popping up on your screen as you exit, and your participation is appreciated as it will help us to improve our webinars. There is a link that I'm going to send you now in the chat box, and with this link, you'll be able to view a recording of this event on that page, and you can share this link with your colleagues when they register for the recording here as well. So I encourage you to do that. Now, please join us in thanking our speakers, Jeff Heilbronn, Stephen Soignet, and Barbara Surchai. We hope that you found the webinar informative. Have a great day, everyone. Thank you for coming.